Welcome to the GlobalRPh Carboplatin dosing review that focuses on the latest changes in the literature from 2022 through 2024. Please like and subscribe to stay informed of similar releases in the future. The right dose makes all the difference between success and failure in cancer treatment. Carboplatin has been the lifeblood of chemotherapy, and its dosing requirements continue to evolve as we learn more about how patients respond differently to treatment. The dosing guidelines underwent the most important changes between 2022 and 2024. These changes have transformed our approach to dose calculations and adjustments across patient groups. Medical teams now have a better grasp of kidney function assessment and patient-specific factors that shape treatment outcomes. Modern GFR assessment methods and patient-specific factors have led to remarkable improvements in dosing accuracy. These updates boost treatment effectiveness and lower the risk of side effects while delivering the best therapeutic benefits. This video will walk you through the latest dosing standards and show you how to put them into practice in clinical settings. Current carboplatin dosing standards. The ADA-KD International Consensus Guidelines have transformed how we administer this drug. Major changes in dosing protocols now focus on individualized patient care without compromising therapeutic effectiveness. 2024 International Consensus Guidelines. ADA-KD recommendations form the foundation of current dosing. These guidelines stress the importance of keeping original target AUC levels, even when patients have kidney dysfunction. Traditional practices of automatic dose reductions have been abandoned because such adjustments could compromise clinical benefits. The removal of the 125 ml per minute cap, previously used in Calvert formula calculations, marks a major change. Carboplatin differs from other anti-cancer agents in conventional dosing. It doesn't follow the typical body surface area-based dosing approach. The connection between platelet nadir and kinetics plays a vital role in determining the best dosing strategies.
Check one, check.
Key changes from previous recommendations. Our current standards include these important modifications: elimination of automatic dose reductions for kidney dysfunction, removal of kidney function capping at 125 ml per minute, implementation of selective dose recalculation protocols. Dose recalculation is now recommended only when baseline kidney function changes exceed 20% or when the patient's clinical status changes significantly. This focused approach helps maintain consistent treatment while keeping patients safe. Implementation timeline for new standards. The EVIQ protocol system has rolled out these updated guidelines systematically. More than 700 protocols across clinical settings have received complete updates. Sequential updates by tumor stream began in July 2023. Healthcare providers received well-laid-out training materials and communication protocols. ADA-KD reference committee meetings reviewed and approved all protocol changes. These changes reflect our deeper understanding of carboplatin pharmacokinetics and patient responses. Pediatric patients follow special protocols, with target AUC values between 5.2 and 7.8 milligrams per milliliter/minute for specific populations. Modern GFR assessment methods. The medical community's approach to measuring GFR continues to evolve. Recent advances have changed how we determine carboplatin dosing accuracy. New precise methodologies have revolutionized GFR estimation, the CKD. EPI 2021 equation stands as the quickest way to estimate GFR accurately. Leading organizations like the National Kidney Foundation and KDIGO have endorsed this method. This latest version marks a crucial step forward by eliminating the race coefficient from earlier versions. The formula yields more consistent results and produces a narrower range of eGFR values than older methods. The shift from traditional methods to CKD, EPI offers clear advantages. Current assay compatibility leads to more precise GFR estimation. Dosing variations decrease due to a narrower range of eGFR values. BSA indexing capabilities enhance accuracy. Research shows that CKD, EPI equations outperform the Cockcroft-Gault formula, the latter ranked poorly because of its high mean percent error compared to measured GFR. BSA adjustment proves valuable by minimizing differences in eGFR and subsequent carboplatin dosing across various estimation methods. Direct GFR measurement becomes necessary in specific cases. Patients with extreme body composition variations, cases with significant muscle mass changes, and individuals with eGFR. Patient-specific dosing considerations. Patient characteristics play a central role in optimizing therapy. Our observations show that factors specific to each patient affect drug metabolism and treatment outcomes by a lot. This demands careful attention to dosing strategies. Body weight calculations need sophisticated approaches that go beyond simple BMI measurements. The American Society of Clinical Oncology. Clinical practice guidelines tell us to use actual body weight for chemotherapy dosing in all patients treated with curative intent, whatever their obesity status. Evidence shows no difference in progression-free survival or overall survival when obese patients get the same chemotherapy dose intensity as non-obese patients. Our established guidelines for infants and neonates show that a target AUC of 5.2 milligrams per milliliter minute works well for infant patients. Patients 10 kilograms or less need weight-based dosing of 6 milligrams per kilogram per day. Patients less than 5 kilograms don't need additional dose reductions based on current evidence. Body composition affects metabolism and toxicity. The distribution of muscle and fat compartments can predict variations in toxicity profiles. Patients with significant muscle mass loss might receive higher relative doses of chemotherapy agents because of their reduced muscle mass. This can lead to increased toxicity. The core body composition factors include fat-free mass, which relates to drug clearance, muscle density, which affects drug distribution, and visceral and subcutaneous fat proportions. Our work with drug interactions reveals liver function's vital role in carboplatin clearance. Obese patients' fat accumulation in the liver can alter blood flow and decrease clearance rates. These patients often show higher absolute drug clearance compared to non-obese individuals because clearance relates linearly to lean body mass. We use therapeutic drug monitoring, or TDM, and target concentration intervention, or TCI, to optimize dosing in complex cases. These methods look at multiple factors: drug and metabolite exposure, age and weight parameters, serum creatinine levels, hepatic and renal function status, and drug-drug interactions. These factors help us predict drug exposure accurately and personalize doses between cycles. This approach proves valuable especially when you have patients with multiple comorbidities or those taking concurrent medications. Clinical implementation strategies. Healthcare institutions need reliable systems and protocols to implement carboplatin dosing guidelines properly. A detailed approach to clinical implementation will give both accuracy and consistency in patient care. Monitoring and dose adjustment. Patients who receive carboplatin need careful monitoring and dose adjustments. A systematic approach helps achieve the best therapeutic outcomes with minimal side effects. Protocols should be based on clinical experience and research data. Therapeutic drug monitoring protocols. The therapeutic drug monitoring, or TDM, approach has transformed how we give carboplatin. Patients on multi-day treatment need 3 1 milliliter blood samples, mid-infusion, end of infusion, and 1 to 2 hours post-infusion. This method works well. 75% of patients needed dose adjustments to reach target AUC values. Without TDM, data shows 44% of treatment cycles would be 20% or more below target cumulative AUC, and 5% of cycles would be 20% or more above target cumulative AUC. Managing adverse effects. Bone marrow suppression remains our biggest concern because it depends on and limits the dose. Single-agent carboplatin therapy usually shows a median nadir at day 21. Recommended monitoring: regular peripheral blood count checks, platelet level assessment, neutrophil count monitoring, and hemoglobin level tracking. Dose modification guidelines. Clinicians should base dose changes on creatinine clearance values and how patients responded to previous treatment. Platelet and neutrophil counts guide later dose adjustments. Live monitoring helps pediatric patients most because their drug clearance can change significantly between treatment cycles. This helps avoid giving too much or too little drug. Experienced cancer chemotherapy physicians must supervise all treatments. It is important to watch closely for allergic reactions that can happen minutes after giving the drug, especially in patients who have had platinum treatment before. These protocols help achieve consistent results while keeping side effects at acceptable levels. TDM-based dose adjustments help reach target AUC values in 12 out of 13 courses of treatment. Future directions in dosing. Cancer treatment is changing faster than ever. New technology and personalized approaches are reshaping how we dose this drug. Traditional dosing methods are giving way to more sophisticated patient-specific strategies. Artificial intelligence applications. AI is changing how we monitor and make decisions about therapy. AI systems have shown remarkable results. In image interpretation, AI changes qualitative analysis into measurable, repeatable results. In tumor monitoring, AI makes segmentation and response tracking automatic. In diagnostic integration, AI brings together radiographic, genomic, and pathological data, and in risk assessment, AI spots high-risk patients with better accuracy. AI's ability to assess immunotherapy response through radiomic biomarker recognition stands out. It excels at spotting complex patterns in images and makes tumor measurements more reliable. Personalized medicine approaches. Real-time molecular profiling of individual tumors has changed dosing. Biomarkers are now a game changer in personalized medicine. They help us tell apart genotypic and phenotypic traits of individual tumors, which guides our treatment choices. Combining metabolic profiling with mutational analysis shows how tumors respond to treatment. This guides both treatment choices and disease monitoring. Clinical trials now focus on beating drug resistance. Understanding how tumors adapt to therapy will help create long-term strategies that work even as cancer cells evolve. Conclusion. Recent guideline updates, better GFR assessment methods, and patient-specific factors have advanced dosing practices. Electronic health record systems and careful monitoring protocols now support precise dosing strategies based on each patient's response. Up-to-the-minute drug monitoring has become the quickest way to get the best treatment results while keeping side effects in check. These tools, along with our expanding knowledge of tumor biology and patient factors, will help doctors fine-tune treatment approaches for better outcomes. Molecular profiling and advanced imaging techniques will guide each patient's treatment decisions as carboplatin dosing moves toward tailored medicine. I hope you enjoyed this brief update. Our goal was to focus on some of the critical dosing changes. Consensus guidelines continue to evolve. The description section below includes references used in the preparation of this video.